morning everyone. My name is Inesh, MSP 12. Before I begin, the committee approval has been given for the study from our hospital, and my topic for today is double trouble, bilateral peripapillary choroidal neurovascular membrane. So choroid neurovascularization includes abnormal growth of vessels from the choroidal vasculature to the neurosensory retina through the Brooks membrane. Clinical manifestations include subretinal hemorrhage, subretinal fluid, intraretinal fluid and exudation. Thus, a large period can elapse between the anatomical onset of disease and visual deterioration. Peripapillary choroidal neurovascular membrane is a type of choroidal neurovascular membrane that is located near the optic disc. PCNM can result in severe visual loss. In a large proportion of PCNM, the cause is idiopathic, and the other causes are post-inflammatory, angioid streaks, optic disc drusen, and papilledema. They have a very poor visual outcome, includes hyperglycemia, and idiopathic intracranial hypertension. The best corrected visual acuity, BCVA, for the right eye was counting fingers at half meter, left eye was 6/36, near vision, right eye less than n/36, and left eye n/10. Anterior segment examination and the remaining examinations were normal in both the eyes. As you can see for the fundus picture, both eyes, blurring of the disc margin with peripapillary edema is seen, along with grayish-yellow membrane temporal to the disc margin with subretinal fluid, subretinal hemorrhage, and exudation can be noted as well. OCT images shows retinal fiber layer thickening in both the eyes and confirm the presence of peripapillary CNVM with subretinal and intraretinal fluid. She received 3 injections of bevacizumab, an anti-VEGF agent, at monthly intervals in both the eyes, right eye followed by the left. Post-injection, the right eye showed minimal residual subretinal fluid and retinal edema, and BCVA was counting fingers at 2.5 meters. As per for the left eye, scarring of CNVM and resolution of SRF and IRF. BCVA was 6/36 and n/10. So this was first described by Lopez and Green scientists in 1928. Consequently, visual acuity is threatened by retinal edema, hemorrhages, and neovascular membrane ingrown in macula. The progression of the disease disrupts retinal structure and function, leading towards the irreversible vision loss. There are several treatment modalities including laser photodynamic therapy, vertiporphin, surgical excision, and as we discussed, anti-VEGF treatment as well. Anti-VEGF treatment is one of the most exciting advances that causes pharmacological manipulation of the neovascularization within the eye, thus preventing leaky vessel formation and traction with the purpose of maintaining the integrity of papulovascular bundle. In our case, subsequent anti-VEGF injections did cause improvement of the patient's vision. Thus, this case report highlights the effectiveness of anti-VEGF therapy in the treatment of PCNM secondary to IIH. A correct pre-intervention identification of the growth side of the membrane, early diagnosis and intervention helps maintain visual acuity better and could help prevent the progression and process of the disease and improve the visual outcome. Thank you. These are the references.
The differential diagnosis?
Differential diagnosis for CNVM can be ARMD, age-related macular degeneration. Then we can have polypoidal choroidal vasculopathy and cystoid macular edema.
Thank you.
Thank you.
Any other treatment?